maybe in closing, one last comment, be great to get your take on it too, but one of the things that's been really gratifying to see just in the last couple of years, last, 1 to 5 years, is a real focus on number one, recognizing that there are dramatic disparities in the care that we're giving with regard to kind of vulnerable populations, a real outsized burden on the Black community in terms of, not having a higher amputation rate, not getting revascularization at the same rate, not being on the same medications, taking a longer time to get revascularization. The same with the Latinx community, and I think it's a real focus of our field, and it's long overdue. But I think it's great to see. We've got a long way to go to understand what the different components of the disparate care is. But I'm curious, was that prevalent in your own training, and do you share that sentiment, or do you see it a little bit differently?
No, absolutely. And I think where we are standing right now is the point where we're acknowledging that these things exist, and where we would like to go is figuring out how do we actually fix them. But certainly in my training, I have seen a lot of this. My training, I had a wide variety of sort of settings. So you had some of the more traditional academic hospital with more of a community-based, and then a county hospital that's more safety net. And you see a lot of really severe end-stage disease there, patients who just didn't really have access to care, and who have a lot of other factors that really play into their healthcare. So some of these, what we call social determinants of health. So, for example, how far do you have to travel in order to get a fresh fruit or vegetable? Because if you have to travel significant distances, the likelihood that you're going to have the time, the energy, the money to go all that way to buy, food you need for a very healthy meal is relatively low, versus somebody who lives in perhaps a more affluent neighborhood or near a grocery store. It's very easy to follow the diet that your endocrinologist or primary care physician recommended to you, a low salt, low sugar, all those dietary choices become not choices if where you happen to be living or your economic situation or your social group somehow is sort of impacting the availability of those foods. And so I think that certainly coming from San Francisco, there's been a big push to start to understand some of these things that are really impacting a patient's outcome, that have a lot less to do with the actual surgery that they get, and a lot more to do with just how they're going to respond to that surgery, how they're going to heal afterwards, what kind of risk factors are going to send them right back with a new set of problems. And certainly that, I feel like, is a big focus as people are realizing how impactful this really is.
Yeah, no, that's great. The only thing I would add to it is some great work's being done in terms of figuring out how to optimize care in kind of remote areas of the country, and, really utilizing remote care, a patient taking a picture of their foot or on a Zoom call, kind of doing a foot exam remotely and looking at a wound, looking at an ulcer, tracking it over time. Because obviously it's a challenge if you have to go 4 hours or 2 hours or 6 hours to get access to, a center that can really take on challenging critical limb patients. So a lot of promise and hope that we're going to move a good distance in kind of rectifying that, understanding it better, and kind of bringing better care to all the patients that need it. So listen, this has been a great discussion. Really appreciate your perspective, and really appreciate everyone joining us today, and hopefully you found this helpful. Take care.
Thank you so much. It's been lovely to have this kind of discussion.